All right, so it looks like we have our participants in the room. So I'll just go ahead and introduce Dr. Gillespie. So Dr. Gillespie, MD, MHPE, is a general pediatrician with the Children's Clinic in Portland. He attended medical school at Oregon Health Sciences University, graduating in 1997, and completed his residency and chief residency at Rush Children's Hospital in Chicago, Illinois in 2001. He also earned a Master of Health Professions Education from University of Illinois, Chicago in 2007. He has served as the past medical director of the Oregon Pediatric Improvement Partnership from 2010 to 2016, and as the medical director of quality improvement for the Children's Health Alliance from 2007 to 2010. He currently conducts clinical research on assessment of parental adverse childhood experiences, which has been published in Journal of Child and Adolescent Trauma, Pediatrics, and Pediatric Annals. As a consultant, he educates providers, patients, and policymakers on the effects of ACEs on lifelong health and wellness, and specifically on the effects of parental trauma on child development. He also serves on the board of directors for Health Share, the largest Medicaid coordinated care organization in Oregon. So please join me in welcoming Dr. Gillespie, and I'll hand it over to you.
Thank you, and welcome everybody. I really appreciate the opportunity to talk to you today. Most of the trainings that I do have to do with screening in some capacity. So how to actually screen for adverse childhood experiences or for trauma. But one of the conversations that always comes up in the course of those trainings is, what do I do when I find it? If I actually have somebody identify trauma or ACEs to me, then what do I do? And I think that a lot of providers really feel like the conversation around trauma or around ACEs is out of our wheelhouse. And certainly a lot of pediatricians and medical providers feel like this is something that we're not trained to do. So the purpose really that I have in this particular presentation is to point out that these are all skills that you already exist, that already exist in your toolbox. And so the way I'm going to do that, I'm going to give you a little bit of background in terms of how I see our role as primary care providers. But then we're going to get into some cases in terms of how this is actually presented in my pediatric office. Now, understanding that my screening protocol really involves screening parents for their adverse childhood experiences. And as was mentioned earlier, most of what we're looking at is how parent adverse childhood experiences do affect kids' development. So there is some bias in that, but I think that many of the skills that we talk about apply to any sort of disclosure about trauma. So I'm hoping this will be interactive. So I'm certainly happy to have people unmute themselves and jump in. And particularly when we get into the cases, I hope that that part will be a little bit more of a conversation. So the assumption that we're starting with is that you've already detected some form of toxic stress, either by signs and symptoms, by screening, or by surveillance. And so now what we're going to talk about is the now what. And again, just acknowledging that this is out of our comfort zone oftentimes, and really something that we feel like we haven't been trained to do. But I think that difficult conversations is very much a part of our job. And so this is something that you probably have done already in a different format. So certainly something that I think everyone here has the capacity to do. So I think a few things just to frame the conversation. The first is that when it comes to screening itself, I think that people oftentimes fear that if you do screening for trauma in primary care practices, that it's going to blow up your schedule. You're going to go completely off the rails for the rest of the day. You're going to have a family that falls apart. And really what all the pioneering practices have found is that screening in practice is actually very feasible. That it doesn't take as long as people would expect. The average conversation only lasts a few minutes. And the vast majority of the time, the immediate plan doesn't change when a patient discloses trauma. So that I think is the first thing to think about, because I think a lot of people kind of worry about what resources am I going to have to provide and what community-based organizations will I need to refer to. And if you get into that kind of mindset where you're planning out what you're going to do, you're not present for the conversation. So just remember that this is only most of the time news for the provider, not for the patient, that there's been an experience of trauma. The second, because I think a lot of people feel like patients and parents are going to not want to be asked, and they're going to resist being engaged in these kind of conversations. But focus groups have really found that parents see the importance of ACEs and trauma to their health. They appreciate the conversation, and a lot of times parents, if they have a history of trauma, often worry that they're going to repeat those patterns for their own children. And having someone just bring up the conversation and face it and bring it out into the open oftentimes is a relief to most families. And they additionally don't really mind the results being recorded in the records, which is another thing that I think many people are afraid of. And ultimately, I think parents look to pediatricians for guidance. So they see us as trusted change agents, and we're viewed as the bridge to needed resources. So when families are asked questions about trauma and we respond in a way that is empathetic and gets them the resources that they need, this is the role that they see us as playing in their child and family health. We also know that teaching resilience skills can mitigate the effects of ACEs, and this is something that can be done within practice. This data comes from the 2016 National Survey of Children's Health, where kids who, between the ages of 6 and 17 who had 2 or more ACEs but learned to stay calm and in control when faced with challenges, over 3 times more likely to be engaged in school compared to peers who had not learned these skills. And even more importantly is that positive relationships with providers matter for building that resilience. So kids with 2 or more ACEs whose parents report that their child's care providers always listen, spend needed time, and give needed information are more than 1.5 times more likely to live in families that practice 4 basic resilience skills. And kids whose parents report always having positive communication with their child's healthcare providers are more likely to practice 3 or more out of recommended protective family routines and habits. These are things like having a good bedtime routine, reading daily, things like that. And what I want to really emphasize on this part is that this data really mostly has to do with providers listening. So that's not a particularly special skill. This is something that we all have the ability to do. And again, I think that when most people think about talking about trauma or ACEs with their families or with their patients, they're worried that they're going to kick a hornet's nest and really kind of end up in a situation that is dangerous or that is difficult or harmful to navigate. And I think that the first thing to remember is that listening is therapeutic. So listening to our patients is therapy by itself. And one of my mentors, who's a developmental behavioral pediatrician here in the Portland area, said that when something becomes speakable, it becomes tolerable. So when you're giving families and patients the opportunity to draw the connections between their emotional brain and their thinking brain, that's the first step towards healing and integration. In mental health, this is referred to as creating a trauma narrative. And I think that when you're able to put words to what you've experienced, that's really the first step in terms of being able to organize your reactions and your thoughts to that particular experience, and then move forward with the healing process. I think motivational interviewing also gives us some principles to think about when it comes to addressing trauma. And the first is really about abandoning the righting reflex. The righting reflex is the idea that providers, when they're faced with a challenge or with a problem, have the trained tendency to want to fix the problem immediately. That's the righting reflex. If the boat is listing to port, then our job is to right the ship. And oftentimes, if we're thinking about what the solutions are for ourselves without actually connecting with the families to find out what it is that they need, or what would be helpful to them, then we're missing an opportunity. And so motivational interviewing would suggest that the solutions to patients' problems are often found within the patients themselves. I think that it's hard to talk about trauma conversations in practice without thinking about how providers take care of themselves as well. And so we use the analogy on the airplane of putting on your own oxygen mask first. And this is for a couple of reasons. Obviously, it's important for us to take care of ourselves as we're having these conversations, because many of us as providers have also experienced trauma. And so these may be triggering conversations for us. And really, if we're not taking care of ourselves, then this can risk injury to our own mental health. And so it's important for how we engage in the conversations versus resisting the conversations potentially. But I think the other thing to think about is what's referred to as parallel process. So this is an idea from mental health that as we navigate our own trauma histories or navigate our own self-care, that we're actually using our own experiences as an example. So I teach resilience skills and breathing exercises and all those sorts of things in my practice on a daily basis, partly because it helps me, but it also helps the family if they're seeing the sort of things that I do to take care of myself. It helps them to understand ways that they can take care of themselves as well. I think ultimately it comes down to the philosophy of you're not alone, it's not your fault, and I will help you. And if you're starting at that place in terms of how you're approaching the conversations, then you're going to get a lot further than you think. Back to the idea that listening is therapeutic, the corollary to that is that who the listener is matters. So if a person has experienced trauma like ACEs, authority figures, including parents and caregivers, schools, healthcare systems, mental health institutions, and so forth, were the ones that were responsible for inflicting the trauma in the first place. Now, patients see us as authority figures, whether we feel like we are or not, or whether we like that role or not. And so when an authority figure becomes the listener, we actually become resilience factors for that family, because what we're showing is that we as adults can tolerate the conversation. The flip side of that is that if there is a disclosure of trauma in our practice, and we don't respond to it, if we don't say something, then we're telling the disclosure that the history is not important or that they are not safe talking about this. And so I think that being an active listener and also tolerating the conversation, again, goes a long ways towards helping people heal. This was studied by the Trauma Healing Project here in Oregon, in Eugene, where they did the Survivor Voices study several different times. And a couple of the things that they found is that when survivors said that they'd been listened to with compassion, they were almost 3 times more likely to report being mostly or completely healed. That's just listening. So again, not a particularly special skill. This is something that we all have the ability to do. When survivors believed that people understood the impact of trauma on their lives, they were over 2 times more likely to report being mostly or completely healed. This is empathy, right? And when survivors believed that people knew how to help them heal, they are again over 2 times more likely to report being mostly or completely healed. Again, not particularly special skills that we need to have. This is about listening and having empathy for our families. I always see success in our conversations about ACEs and trauma as being relational. So have I helped the family strengthen their relationship with me as a provider? Mostly that to me is about having a culture of safety within our office, so that if we leave a conversation about trauma or about ACEs with the family feeling that they're able to talk to me about whatever goes wrong in their family or whatever is going wrong in their social milieu, then that's a success to me. Success is never really about forcing a disclosure, I don't think. I think that has to be up to the family, up to the patient always. And so success is really, to me, more about the culture change. As I mentioned earlier, if we're leaning on our training to fix everything, that whole idea of the writing reflex, then what we're doing is we're planning our response in our head rather than being present and listening to the conversation and listening to the disclosure. And so I think it's important to make sure that we're suspending that and just focusing on just listening. I think one of the trauma-informed care mantras that I've always clung to, because I think it's an important one, is the idea of, instead of thinking what's wrong with this person, think what happened to this person. And then in addition, how can I help? And I think that when it comes to dealing with patients and parents and families whose behaviors seem difficult or aggressive or obstinate, if you understand that there's something that's happened to that person rather than thinking about what's wrong with them, it shifts our mindset to a place where we're better prepared to help the family. Vince Felitti, who you probably know is one of the authors of the original ACE study, he did some data just on asking a simple follow-up question. So how did that affect you later in life? And found that inappropriate utilization actually improved pretty dramatically. So he found that there were decreases in primary care visits, decreases in unnecessary ER visits, and decreases in hospitalizations. Now that again is not a particularly special skill. That is just simply asking a question. How did that affect you later in life? And that again is getting back to the idea of helping patients, parents, or families to create that trauma narrative, to understand how their past experiences may be affecting them now. So in terms of resilience itself, I think there are a couple of things to think through. And the first, to me, what do I do when I find it? The first is to keep calm, right? And to remember our role. This is comes from a study that was published in Pediatrics in 2017, and these are modifiable resilience factors in pediatrics. So these are 5 things that have good evidence base behind them in terms of things that we can do in primary care. The first is a positive appraisal style and executive functioning skills. So helping families to recognize if they experience trauma, that this isn't an internal something wrong with you as a person that made this happen to you, but really kind of getting to understand locus of control, and that when bad things happen to you, it isn't a reflection of your personality. The second is responsive or positive parenting skill building. This is something that as pediatricians, we should very much keep in our domain. And this is something that we think is very important in terms of helping people to recover from trauma. The third is identifying and getting connection to treatment for maternal mental health problems. And many people who are experts in trauma-informed care say that if you're not ready to screen for ACEs or for trauma, for example, you should at least be looking for maternal depression and helping those families to a path for recovery. Teaching self-care skills and routines. And then the last part is really just enhancing trauma understanding. And a lot of people, when they hear from us about how trauma can affect health and mental health, that by itself is an intervention that helps many people to understand why things have been the way that they are for their life trajectory. The common factors approach, which is comes from the mental health toolkit, is meant to be a framework for helping navigate conversations around mental health conversations. So if you're talking about what primary care should be doing in the face of anxiety or depression or ADHD, these are the conversation points or the framework that you want to rely on. And I think that very much applies to conversations around trauma as well. So hope, the idea of increasing a family's hopefulness by describing realistic expectations for improvement and reinforcing strengths and asset you see in the child and family. Empathy, so communicating empathy by listening attentively. Language, which is about using the family's own language to reflect your understanding of the problem. Loyalty is about us committing to help and to support the family. Permission, asking the family's permission for you to ask more in-depth questions and to make further suggestions for evaluation and management. Partnership, and this is providers basically committing to partnering with families to agree on some next steps. And then the plan part is establishing a first incremental step for how you're gonna help the family. To my mind, when you find trauma, there are 4 things that you want to look for. The first is an immediate assessment of the child and family safety. Second is figuring out what assets, resources, and resiliencies happen in the family. Third is to do any follow-up tools for assessing mental health in patients as needed. And then finally, connecting with appropriate resources. When I do my conversations around parent ACEs, I developed this script from a number of different places that I think help most of the conversations to kind of have some structure and to provide some guardrails so that they don't go too out of control. And I think having a script like this of some questions that you can think through in the case of trauma, again, helps you to feel more confident in terms of navigating the conversation. To me, the first part is thanking parents or families about opening up about their experiences, which really validates the importance of the conversation. And then asking, are there any of these experiences that still bother you now, which gets at that safety issue that I was just talking about. Of those that no longer bother you, how do you get to the point that they don't bother you anymore? This gets at resilience. So was this a lot of mental health work that you did? Was this a family member or other connection that you had that helped? Was it your own internal drive and commitment to healing that did it? And then you can assess if those things still exist. And then for me, how do you think these experiences affect your parenting now? Which gets back to the question similar to what Dr. Felitti used in his conversations, but really framing it more as a parenting issue, again, because of the way that I do my screening. When it comes to steps and developing a plan, the Center for Youth Wellness talks about 7 basic domains of wellness. So these are all pretty pretty standard things that you want to think about. Sleep, nutrition, exercise, supportive relationships, mindfulness or meditation, good mental health, and getting out in nature. These are the domains that you'll want to think about when you're developing that plan. Resilience. I think it's important to kind of give families an idea of what resilience means. Conversations around trauma and ACEs can be very much one-sided, and what you want to do is help people to understand that there's a message of hope as well, that ACEs are not our destiny, and that resilience gives us a chance to heal and to shape our future. And I think a lot of times if you help people understand what resilience factors are, they can identify where they need to strengthen their own systems. My favorite framework for resilience is the 7 C's that comes from Ken Ginsberg. I won't define each of these individually, but I will refer you to his website, which I think is a good resource for kind of thinking through how we frame resilience. There's also a book that he wrote about building resilience in children and teens. But the 7 C's are connection, confidence, competence, character, coping, control, and contribution. And I think identifying where those different pieces can be built within a child or a family's life is going to be important. Now, these are some cases that I wanted to go through to help people understand that these conversations about trauma are easier than you think. So I'm hoping for this part that people will come off mute and sort of jump in. I'm going to open the chat box too, just so that I can see. Perfect. Yeah, you got the Fostering Resilience website up there. That's perfect. Thank you. So some cases. And these are, some of these are coming from my own practice, and some of them are coming from other providers in my office. And so I think, again, this should be hopefully a little bit more interactive. We do our screening for parent ACEs at the 4-month visit for a lot of reasons, but basically this is a 4-month-old who's in for a well visit, and mom's primary concern is colic. And every evening after mom gets home, the infant spends 3 or 4 hours crying every evening. It's a 2-parent household, so there's a 7-year-old sister at home. Mom is working full-time, dad's in training to be a firefighter, and if you know how that training goes, basically dad is out of the house for 48-hour blocks and then home for a day and then back out for 48 hours. So it's almost like being a single parent. And the way mom's day goes is she leaves work, immediately drives through traffic and gets home to relieve the nanny. So in the case of this kid, a lot of times when we're thinking about colic, we go through a history to make sure there isn't any medical reasons for it. And I think everybody kind of jumps right to reflux. But in this case, he's feeding fine, his growth is great, he's not spitting up, and his whole physical exam and review of systems really doesn't add anything to our story. But when I give her the ACE questionnaire, her ACE score is 5, and her parents went through a horrible divorce when she was a kid, where there was domestic violence, there was verbal abuse, both from dad to mom and dad to the kids. There was substance abuse in the household. And so what that immediately makes you think is how would a mom who has come from a very loud and difficult household, how is she going to respond to a yelling infant? And is that going to trigger her fight, flight, or freeze response? And what do we really do? So what would you do? And again, at this point, if you want to jump into the chat box, or if you want to unmute yourself and just give some ideas about what sort of things you would do for this family.
I can start. I think one thing that might be in order is just to talk to the mom about how, like you said, like what response she's having whenever this infant is crying, like what does she feel, and also what is she doing in response to it, to kind of gauge like next steps.
Excellent. And I'm seeing a couple in the chat that are going the same way. Ask mom what she's doing to decompress, help mom find ways to calm herself. And I think that's absolutely on point. There are no wrong answers here. So if anybody else has any thoughts, then certainly jump in.
I think something else is just, as you were sort of encouraging, thanking her for coming in, just acknowledging the fact that it's a big deal to put aside time in your schedule to come to a doctor's appointment visit, that this is something that she's not alone in experiencing, and just sort of starting off from that point of validation.
Great. And I see a couple of people who have commented on support networks and what support mom has. That's excellent. Other thoughts? And I think you guys are right on point. And again, this was the whole point of this presentation, was really think about how these kind of conversations are already in your skill set, right? And so one of the things that I talked to mom about was about resilience and what did she do to help calm herself, and what did she do to take care of herself? And really, again, getting back to the idea that she went from work to rush hour traffic to home to a screaming baby. And there wasn't any timeouts for mom to say, okay, I'm going to take a few minutes for myself. I'm going to do something that is going to help me to calm down. And so, you know, we talked, she actually used to do a lot of yoga before the new baby came. And, you know, with the way the schedule worked out, she didn't really do that anymore. And so I asked her what sort of things she could do to get back to a mindfulness activity or some other way to kind of recharge and relax herself. And what she decided to do is on her way home, she basically just stopped at Starbucks and got a cup of tea and just sat there for 10 minutes because she realized she didn't need to go straight home to the nanny. She could afford 10, 15 minutes to herself. And really, I think that changed her perception a little bit. The colic wasn't entirely gone when she came back at the 2-month visit, but mom's stress was less. And I think one of the things that when you get to know babies, babies respond to caregiver stress basically by doing more crying, right? If they feel like there's some sort of stress in mom, then they feel unsafe. And again, oftentimes that'll kind of create a spiral or a back and forth kind of amplification of the colic. And so I think that very much for mom, it was about getting herself to a place where she was calm. And her perceptions about things were definitely improved too. I think that a couple of punchlines for this one for me, one is that parents often do need that kind of permission for self-care. And they may not always be aware of how their own experiences affect how they handle parenting, stressful situations, or even their balance. I think that one of the things that I always try to teach parents too is that when you're doing self-care and when you're doing some sort of resilience activity, it does a couple of things. Obviously, there are the effects that it has for you, but there are also the modeling that there's the modeling that you're doing for your kids as well. So you're teaching your kids that self-care is important, and you're teaching kids, here are some ways to calm down. Now imagine that 4-month-old a few years later during you know, the toddler tantrum kind of age, which happens to every kid. If that mom has been teaching self-calming behaviors by modeling that for her kids, she's going to have a much easier time as a toddler as well. The next case, and this is one I'm a little embarrassed by because this is one where I feel like I really missed the boat with the first kid. So this is a second-time mom. So it's the first time that she'd filled out the ACE tool because we had implemented it in between the time when she had her first kid and her second kid. And what I found from the assessment tool is that her mom had left when she was 2. So she'd abandoned her and her family, and her dad experienced some depression and substance abuse after that. And when I said to her, how do you think this affects your parenting now, which again is part of my scripting, her response to me was, do you remember how you told me to let my first son cry it out when he wouldn't sleep? I just couldn't do it because I felt like I was abandoning him. And certainly at the time in my practice, you know, a lot of people were still talking about the Ferber method of letting kids cry it out. So, you know, it was a fairly common way to try to approach sleep problems, and it just didn't work for that family. So what would you do? How would you handle this particular situation, and what do you think you need to do? Any thoughts or ideas?
I think for her, like maybe setting her up with supports that could be helpful in modeling, like, if she needs help with modeling of parental behaviors, since she may not have gotten that as a kid.
Yeah.
And then asking her, like, or reminding her, validating her feelings about it, or reminding her that, it's okay that you may not necessarily feel comfortable with this, and setting her up with people who do feel comfortable with those kinds of things.
Great.
I as a well, I'm in education, but I would admit my mistake and say, this is what we were trained to do at that point in time, and you need to do what you feel is best for you and your child.
Absolutely. And that's, I think, one of the big things for me is that, wow, thank you for sharing that with me. And I'm so sorry that I gave you advice that didn't work. And I think for providers, a lot of times when patients are quote unquote non-compliant, or they don't follow through on our recommendations, we make assumptions about why that is. And this was really very much a bad assumption on my part, that if they weren't doing the sleep training the way that I told them to, then there was something wrong with that, right? And I think that what you guys are getting at is exactly right, that what you have to figure out is what works for that mom in terms of sleep training, right? And if that didn't work for her, then what's something that would be better, right? So what would be something that she would feel comfortable with doing? And really what we did is we talked a little bit about other methods of sleep training. So what is mom comfortable with, right? And I think the other thing to remember is that dad's in the picture here. And so dad didn't have that experience. And so how does dad get more involved in helping with the sleep training to give mom a break, right? But I will say that once mom said the words out loud about what she was experiencing, she'd never really put two and two together, right? Because the follow-up sentence after she said, I feel like I'm abandoning my kid the way that my mom abandoned me, she said, but that's not really what's happening, is it? And so she immediately felt differently, because I don't think she'd given voice to where her fears were coming from. And so really, to me, a lot of it had to do with getting down to what mom was comfortable with, but also helping her to tell her story. So that drawing that connection between, her thoughts and her feelings really helped her to understand where her resistance to sleep training was coming from. And as I mentioned, I think that when our advice isn't followed, it's oftentimes not for the reasons that we think, right? Now, I call this case teenage tantrums, or the worst clinical visit I've ever had. And this was a 15-year-old girl who was doing, in medical terms, everything wrong, who's there for a well visit, and she's there with her mom. And so kind of the list of problems, the way that it was presented to me, first of all, was school truancy, because she was being kicked out of the last-ditch high school that she was sent to. So she'd been in all sorts of high school programs. None of them had really been a fit. She was skipping out all the time, and so she was in danger of being kicked out of school altogether. She was having violent fights with her mom to the point where she was throwing furniture and breaking things in the house, and mom had to call the police several times to protect herself. She was having unprotected sex with her quote-unquote boyfriend, who is 11 years older than she is. So there's that whole can of worms about her being a minor. And she was taking meth, marijuana, and cocaine on a regular basis. And I'm sure most of the providers in the room are kind of feeling your blood pressure go up a little bit, that this kind of case scenario, unfortunately for teenagers, is not super uncommon. And so you have to kind of figure out how you're going to navigate this conversation, right? And so after figuring out this history, what I asked her is if she had any goals, really because I wanted to get down to her resilience and her future planning, and see if we could kind of anchor the conversation that way. And the response to me was, you think I'm having unprotected sex because I don't have any goals? You're a very unfriendly word for a body part, basically, is how she said it. And so she unfortunately saw right through what I was trying to do. And she was not having it. So difficult situation, but what do you do? What would you do in that kind of conversation?
I would ask, how can I help you? What do you need me to do for you right now?
Mm-hmm.
And then we'll base everything from that. I'm a high school counselor and I get all some of that, what you just said, all the time. So I have to ask them, how can I help you now?
Yeah, very good. Other thoughts?
Along the same lines, I would maybe ask her if there was one thing she needed help with or she wanted to change, what would it be and how can I help do that? So kind of set one goal maybe.
Good.
Maybe ask her what happened that started her on that path.
Very good. Other thoughts? I think probably the first thing to think of is what you don't do, right? Because it's really easy when a teenager swears at you or is doing these kinds of high-risk behaviors. It's really easy to get into drill sergeant mode where you tell somebody, you know, that everything they're doing is wrong and, you know, blah, 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 that you need to pull this together and whatever. And so you need to suppress that initial instinct to fight back, right? And to me, what I did is first I asked the mom to leave the room because obviously the teenager needs to have a conversation with me one-on-one to be able to really open up and tell her story. And what I did is I asked her about her ACEs and her childhood experiences. And she reported her ACE score as 5. And basically her father was out of the picture after going to jail for drug abuse. So that's 3 right there. Verbal abuse, emotional neglect were part of her perception as well. And so again, getting into goals and coping strategy and boosting her sense of competence was really the important part. And Vince Felitti put it this way, that it's hard to get enough of something that almost works. So when we look at the sort of dysfunctional behaviors that we see patients doing, whether that's drug abuse, overeating, high-risk sexual behavior, those sorts of things for somebody who's experienced trauma shuts off your fight or flight response for a little bit so that you feel normal for a little bit. And so all of these behaviors that she was going through or that she was engaging in were really ways that she was trying to make herself feel normal just for a short period of time. And honestly, just having the conversation with her was an important first step for her. Because I think nobody had given her an opportunity to tell her side of the story. And I think that if you start thinking about taking away the coping strategies that she has without putting something else in its place, it is going to lead to failure, basically. And so I talked to her a lot about what she enjoyed doing and what she puts in her emotional piggy bank, as I put it, or positive capital, as mental health providers put it. And she started talking to me about photography and how she really loved doing photography. She hadn't done it for a long time, but I thought about, you know, how do we get her to redo some of those things that she really enjoys? And honestly, between the conversation and talking a little bit about her own interests, she came back at the next visit. And she had transferred to a gateway program at our community college where she could get a GED and associate's degree at the same time. She stopped all drugs except marijuana, and she ditched her much older boyfriend at that point. And when I asked her what had changed, her response to me was, the kids at that last school were losers. They didn't have any goals, which, if you think about it, she turned my language back on me when I talked about goals and she had referred to me as that body part. It still sunk in, and it was still enough to kind of plant a seed for her that honestly she had the opportunity and the chance to do something better. And so you know, the relationship changed pretty significantly just by me doing some listening and really hearing her story. Now I just got a message saying that we had 5 more minutes. Is that true?
Just 1 or 2 more minutes before this room's going to close.
Okay. All right, so I'm gonna I'll rip through the next couple cases pretty quick. So this is a 12-year-old who comes in for a well visit. Mom's big concern is his grades are slipping. He used to be a B student, now he's a C or D student. He's in a new school this year. He cries when he talks about how he hasn't made any friends. He's not disruptive. There is some past history of anxiety, but there are no thoughts of self-harm. And typically our medical response to that would be to think about ADHD, learning disabilities, anxiety, depression, things like that. But really what we find if we get into a trauma history is that the kids, dad's in jail. Both parents have had a history of substance abuse. That's why dad's in jail. Parents are divorced. Mom has a history of anxiety and depression. And used to live with his grandmother, but has been moved in with mom now that she has her act together. And I think that in those kind of cases, when you know that the ACE score is at least 4, then you need to kind of think back to those resilience factors again. So connection, really getting him involved in mentorship programs was one of the things we looked at. A Big Brother program, getting him involved in Boys and Girls Clubs where he can do some things that he enjoys like skateboarding, and then some exercise, meditation, youth contact for counseling. So really thinking outside of our medical box and into more of a resilience box is where we want to go with this. We're just about out of time, so I apologize. I wish we had longer to chat, but I'm happy to answer questions. If anybody has any questions, they can get them emailed to me or anything.
So I hope you all enjoyed those breakout sessions on trauma-informed healthcare systems. We will begin our breakout sessions on addressing trauma through policy and advocacy at 3:55. So you can feel free to take a stretch break if you need it or grab some water, and we will reconvene at 3:55.
Dr. Gillespie, thanks for an excellent presentation. I'm sorry we got cut off there at the end.
No worries.
Would you like to share your contact info in the chat box if people have further questions?
Sure.
All right, thank you.